All right, so back with another whiteboard chat talk. I don't know. We need to give this an actual title, but so I put up a poll in my story, Facebook and Instagram. Choice between male sex hormones, hypogonadism, or low male sex hormones, or viewing stress in lab work or spotting stress in lab work. I'm actually kind of surprised this one, but probably end up doing both of them anyhow. Stress is such a hot topic that, I feel like probably ought to do that one, even though I've talked about it a bunch. But if in all reality, though, if we're talking hormones, and same with the thyroid that I talked about in the last one, if we were to look at a giant graph with arrows, everything's going to be in a feedback loop, more or less, to some extent, right? You downregulate this, it's going to upregulate this. It's going to come back around eventually. So I think what's important to understand there is, in short-term situations, we are able to compensate, right? We have like compensatory mechanisms that we can compensate things like stress or poor signaling here or there. Now, in long-term or chronic situations, we can't, right? We can't keep up with that. We may end up with something like hypogonadism. Okay, so let's talk a little bit about what it is and the different types. Main goal here is I want to be able, if you look at labs, that kind of figure out what kind it is and what it might have stemmed from. Now, the causes of this can get pretty complicated because it can trace back to a lot of different things, and it might not be something that's super obvious, so it might take a little more attention or evaluation by a professional or something, but at least this way, if you're looking at labs and you kind of know what the different types are and what might be causing it, because I think the issue, is, do you need hormone replacement, right? That's always the question. And sometimes yes, for sure. Other times no. So I think it's important to know what the heck you're looking at before you make decisions like that, right? So, all right, so first off, overcomplicated signaling cascade, just like thyroid, completely unnecessary. I wish our testes just produced testosterone and we were good to go, right? So in males, this is what we're looking at. So hypothalamus will stimulate GnRH, which is gonadotropin releasing hormone. That will hit the anterior pituitary. That's going to split into two different cells, Leydig cells. Once we get to the testes, split into Leydig cells and Sertoli cells. Leydig cells signaling for testosterone production, Sertoli cells signaling for spermatogenesis. I think that's how you say that. So obviously, sperm production, right? Now, then you'll see here, they're going to signal back up, right? So we have luteinizing hormone and follicle stimulating hormone that are going to help with the stimulating process. These are going to come back up to the top and let us know, hey, we have enough FSH, we have enough LH, or we don't, and then going to, continue looping around with that signaling cascade, right? So some things can happen in here. Oh, and it, obviously worth noting in males, and this does happen in females too. Females do aromatize to some extent, but they're primarily producing estrogen through their ovaries, right? Whereas males are getting their estrogen through aromatization. So this, we'll put estrogen, and there are different types of estrogen. We're mainly looking at estradiol though, so E2. Okay, so if we have issues in this signaling cascade, or we have issues with the testes themselves, then you may end up with hypogonadism. Okay, so what happens at that point? Now, there's a few things that happen. So in this population, there could be people that use performance-enhancing substances that cause shutdown of the entire feedback loop, right? And if you've ever seen, an easy example is if you're on testosterone replacement, you look at your lab work, your FSH and your LH are going to be 0 or less than 0.1 or what, you know, whatever the lab work reads, and that's normal, right? That just means you're not signaling because you don't need a signal because you're taking exogenous hormone prescription or whatever, right? So that's worth noting. And if that happens too long or someone doesn't recover from taking those things, if they're self-medicating, then, you know, they may end up with hypogonadism. But there are other things that can cause it too. There can be, and let's talk about the two types here, primary types anyhow. Primary and secondary. So primary, this is originating from the testes, disease of the testes. I mean, I know that disease is kind of a broad term, but it can mean a bunch of things. I mean, you could have a tumor, a benign tumor or something. It could be quite a few different things. All right, so, but that's what primary is. And there, in this case, a lot of time there's high LH and high FSH, just because we loop back up, we don't have enough of this. So it's like, uh-oh, you know, we need more signaling, we need more signaling, we need more signaling. So it's just like people that might be hypothyroid. They might have high TSH because their TSH is thyroid stimulating hormone. It's trying to say, hey, we need more, we need more. So high. Secondary, this is issue with pituitary or hypothalamus. So it's a signaling issue. It's a signaling issue. Signaling issue, probably going to have low, sometimes normal. It's not always low. But a lot of times it's going to be low LH and FSH, right? So we're having a signaling issue somewhere up in here, and we're not even getting through the steps to produce testosterone. So it's not originating in the testes, it's originating up here somewhere, right? Again, could be a pituitary disorder. That's why a lot of time people, especially younger people that have hypogonadism, they might want to look at pituitary function, especially if they test and they see signaling, you know, they see low T and then they see signaling is low. They're in maybe there's something going on with pituitary because this person's not really at an age where they should have low testosterone levels, right? So they might look up here, they might do something like some kind of imaging, right? To look at pituitary, look at the glands to make sure that there's not a tumor or something else going on up there that's causing an issue. And sometimes there is, sometimes it happens, right? I've worked with a few younger clients that have been prescribed hormone replacement with no prior usage of any types of substances, any drugs or anything, or any type of other prescription medication that might lower it, or stress induced or anything like that. So it can happen. Okay, so what are some other reasons that you might have hypogonadism? I'll go over just some common ones. Biggest one I probably see is stress, right? And stress comes in a couple different forms. Here, especially if we're talking about competitors, there is feedback between, you will get feedback loop disruption between cortisol. A lot of times if you have super high cortisol, you're probably going to have lower testosterone levels. Now, this can come by the way of just chronic stress over time, overtraining chronically, over stress, perceived stress, physical stress, all that stuff, right? It could also be competing too often, right? So especially natural competitors competing too often. I mean, there's plenty of studies on this. It's not anything new. You compete, you're probably going to have low T when you're done, or it's definitely going to be a lot lower than what you started, and it will slowly come back up. As essential functions return, you gain some body fat, you eat more food, all that jazz, right? So that could be the case. Medications is one. This one's super ironic because you'll see the most common one being antidepressants like SSRIs, for example, is a big one. People are depressed because they have low T, and they give them SSRIs, which can lower their T more. All right. Or you have like people that have just been prescribed them for a really long time, and and they end up with low T eventually, maybe partially because of using something like the SSRI for a really long period of time. I know I don't have any actual like data on this in terms of statistics, but I know I've definitely seen a correlation between people that have been prescribed SSRIs for long periods of time and low T, even of people that aren't really in that low T age, where they should be declining. So that's something to keep in mind. And there are other medications that can cause it. So if you're taking a medication, you have low T, I have to do some research, just kind of cross-check and make sure that that's not part of the issue. But those are probably the most common things that I see: stress-induced, medication-induced. The stress one gets complicated, like I said, just because it comes in so many forms, and you're not going to end up with, well, I should say this, it can happen pretty quickly too. So if you were to, and adding other things like drugs and alcohol and smoking and stuff, and obesity also lower it, so chronic inflammation, right? You can lower it in a night. Like, if someone were to hypothetically go and drink a bunch of alcohol and stay up super late and be super stressed out, their T levels are going to be lower the next day for sure, because it's pulsatile, right? It's not linear, so it's not like someone on hormone replacements that's more linear, right? They might have some drop off before their next administration of their injection or their gel or whatever, whatever they're using, and you might have a little bit of that, but it is more pulsatile in somebody that's endogenously producing it, so you could drop it. Now in that case, it's going to go back up. It's not like it's that's a permanent thing. Do that chronically, on the other hand, definitely going to be low. You take someone that's kind of like on the age cusp, maybe they're just in their 30s or mid-30s, just haven't taken care of themselves. They drink too much, they're way overweight, poor diet, all that stuff. They have some low to moderate grade chronic inflammation going on all the time. They're probably going to have that, probably going to be sooner than it should, right? I mean, just the act of fixing those things, losing weight, all that stuff, I've seen people's testosterone levels go up. Even though they are losing body fat, you think they're going to go down, right? No, they went up because they weren't so lean that we were disrupting this, right? So, yeah, that's probably the main gist of it in terms of signaling, feedback loops, primary versus secondary. Make sure you look at LH and FSH in here, right? Here and here. Secondary is probably going to be a little bit lower, higher on primary, and that's going to help you figure out what the cause of this is and probably give you a little more education in terms of fixing it, whether you need to be medicated or whether it's a dietary thing or lifestyle thing or combination of things, medication, right? So that's it for this one. Hopefully that equips you guys a little bit more knowledge to approach this topic. If you're running into it with your doctor or something like that, you can ask for the right testing. If they're not doing it all, you can know what you're looking at on your own testing, for example. So until next time.